par and post-procedural.
Okay. Honorable chairpersons and distinguished audience, Assalamu alaikum and a very good evening. I feel honored to have this opportunity to talk in front of this August gathering. My topic is very long, but time is very short. So I will highlight a brief evaluation about the mitral stenosis, role of echo during and after PTMC. So regarding etiology of mitral stenosis, mainly it is acquired and the rheumatic heart disease is the predominant cause. There are a few cases of congenital, but I will focus on the rheumatic mitral stenosis. So because I will focus on the PTMC, I will talk mainly on the rheumatic mitral stenosis. So what is the pathology of rheumatic mitral stenosis? There is commissural fusion, leaflet thickening, caudal shortening and fusion. There may be superimposed calcification, and lastly, there may be annular calcification. So what we do see in parasternal longus on 2D echo, there is doming of the anterior mitral leaflet, thickening of the leaflets, there is reduced mitral valve orifice, and there is subvalvular change. This thickening may progressively involve chordae. So we can see here the chordae are thickened, and along with there is enlargement of the left atrium. Short axis view showing the commissural fusion, and the mitral valve orifice is elliptical, and the orifice is severely reduced, and it indicates that mitral stenosis is severe. So other 2D features that have to look in association with the mitral valve morphology, here we can see the dilated LA and dilated RV and RA when there is RV volume overload. In each case of the valvular heart disease, ventricular function should be evaluated. Usually in mitral stenosis, ventricular function is normal, but it may be reduced when there is AF with fast ventricular rate, that is tachyarrhythmia induced. For assessment of mitral stenosis severity, M-mode, 2D echo, and Doppler play important role. So on the left, we see the normal mitral valve, and on the right, there is stenosed mitral valve. So there is reduced EF slope, there is anterior motion of the posterior mitral leaflet, fixed relation between the AML and PML, and the reduced mitral valve orifice, and leaflet thickening and calcification are evident on the M-mode finding. So mitral valve measurement on 2D echo by planimetry has the best correlation with the anatomical area, and mitral valve area should be measured in the tip of the leaflet in a plane perpendicular to the valve leaflet. It is elliptical in shape. Normal mitral valve orifice area is 4 to 6 centimeters square. Symptoms do not usually occur until orifice area is less than 1.5 centimeters square. So echo Doppler evaluation include mean and peak transmitted pressure gradient measurement, including VTI, valve area by pressure half time, pulmonary artery pressure, and coexisting mitral regurgitation should be evaluated. Here, example of color flow jet of MS. Here, color Doppler spectral image tracing. It is the measurement of transvalvular gradient from left atrium to LV, and this is the most important factor for determining the physiologic significance of MS. So pressure half time is calculated by tracing the deceleration from the early peak transmitted velocity to a point when the peak mitral velocity fall to its half. Mitral valve area is 220 by pressure half time. When pressure half time is more than 220 milliseconds, then it is severe. Mitral stenosis is considered severe. And if pressure half time is less than 220, then it is other method to assess the severity needed. And it is unreliable immediately post-PTMC because it causes underestimation of the mitral valve area. Classification of mitral stenosis severity, we follow the 2008 ASA recommended guideline. And according to this guideline, when valve area by planimetry is less than 1, it is considered severe. 1 to 1.5 is considered moderate, and less than 1.5, more than 1.5 is considered mild. Supporting feature, that is mean pressure gradient equal to more than 10 millimeter mercury, supports there is severe mitral stenosis. Less than 5 indicates there is mild mitral stenosis, and in between that's 5 to 12 millimeter mercury supports moderate mitral stenosis. Pulmonary artery systolic pressure more than 50 supports severe MS, less than 30 mild, and 30 to 50 moderate. There is another guideline, the 2020 AHA and SSC valvular heart disease guideline, where mitral stenosis is classified in different stages. The difference between these two guidelines, that in AHA SSC 2020 guideline, when mitral stenosis is considered severe when valve area is less than 1.5 centimeters square and pressure half time is more than 150 milliseconds. And when there is presence of symptom, it is considered symptomatic severe. With absence of symptom, it is asymptomatic severe. Doppler parameters are same in two guidelines. When stress echocardiography is indicated, it is indicated to unmasked symptoms when mitral valve area is less than 1.5 centimeters square and there is no or doubtful complaints, and when there is discrepancy between resting Doppler and clinical findings. So for PTMC, to find out the suitability of a case for PTMC, the most widely used is Wilkins score, and it gives a rough guide to the suitability of the valve morphology for PTMC. It looks for the anterior mitral leaflet mobility, thickening, subvalvular caudal involvement, and calcification. The score range from 1 to 4. The total score sum from 4 to 16. And usually a score less than 8 indicates there is a good outcome of PTMC, but there is some limitation of Wilkins score, that it does not consider commissural calcification and there is uneven distribution of the valve morphology. Thus, in general, patient with a score of less than 8 to 9 with no commissural calcification and less than moderate MR have the best outcomes from PTMC. In our institute this year, 89 cases underwent PTMC, and based on the Wilkins score, a score less than 8, 97% cases had good outcome, and based on Wilkins score, a score with equal to or more than 8, 78% had success rate. So in whole the group who had underwent successful PTMC, there is significant reduction in the valve area, peak gradient, mean gradient, and reduction in the PSP. So transesophageal echocardiography is indicated to exclude the LA appendage thrombus before PTMC. On the left, we can see there is the normal pectineate muscle in LA, not thrombus, but on the right, we can see the obvious thrombus by TE. TE also help to guide the transeptal puncture or for positioning of the balloon during PTMC. 3D accuracy has higher accuracy than 2D echo. Measurement in calcified and irregular valve is possible by 3D echo, and measurement after PTMC by 3D echo is accurate. So there is some contraindication for PTMC when valve area is more than 1.5 centimeters square, when there is LA thrombus, more than mild mitral regurgitation, severe or bicommissural calcification, absence of commissural fusion, when there is severe concomitant other valve disease, and concomitant CAD requiring bypass surgery. So here we can see the LA appendage thrombus. On the right, there is valve thrombus, ball valve thrombus. So these short axis view show there is commissural calcification and with calcification within the valve orifice. So PTMC is contraindicated for this patient. So this is a case suitable for PTMC. Parasternal long axis view show that the valves are pliable. There is caudal thickening but no fusion, and color-free imaging shows there is only mild MR and mild air. Short axis view show that commissural fusion and the valve area is considered severe. And on the right, we can see that there is no thrombus in LA or LA appendage is clear. Apical four-chamber view showing that a mild mitral regurgitation and spectral Doppler tracing show that it's a case of severe MS. Thus, this case is suitable for PTMC. So what is the role of echo during PTMC? To guide the procedure and detecting acute complication like atrial or ventricular perforation with tamponade, acute mitral regurgitation, and whether there is any valvular disruption. Evaluating result of PTMC, assessment of valve area, planimetry ideal, pressure half time should not be used, and other Doppler parameters should be measured. Here, post-PTMC follow-up showing that their short axis show that their post-medial commissure is open, and planimeted valve area show the valve area is 1.7, so there is mild residual MS. Apical four-chamber view showing that only mild MR and my spectral Doppler tracing showed that mean gradient is 4 millimeter mercury, that this indicates there is mild residual MS, good outcome. So this post-PTMC follow-up in another cases show minimal tear on the PML, but MR is just more than moderate, so we keep the patient under follow-up. So in conclusion, what we should write in the report of MS, we should comment on etiology of valve disease, severity of MS, whether there is any concomitant other valve lesion, size of LA, PSP, ventricular systolic function, presence of thrombus, suitability of PTMC, and if post-PTMC, we should comment on the current echo status. Thank you for your patient hearing.